time this morning, and I'd actually like to thank all of you guys for getting up a little bit early and sharing breakfast with us. We're going to do a review of the effects of a curcumin supplement on patients with persistent Lyme disease. And as a matter of sort of introduction, my name is Tom Moorcroft. I'm a board-certified family practitioner and specialist in osteopathic manipulation from Berlin, Connecticut, and my practice primarily focuses on integrative treatment of Lyme and other tick-borne illnesses. Lee Silsby has sponsored our breakfast. Although I think they have a really nice product, they're not paying me to tell you anything about that. And I'm really standing up here as a private physician who's trying to relay to you what goes on in my practice and how this product may or may not have benefited my personal patients. So this morning, I'd like to introduce the preliminary results of a pilot study that we've done and sort of get into some of the details of this study and also sort of some of the things that came out of the study that have really sort of prompted us to look to the future and where we might be able to utilize this product. We also have Dr. Philip DeMio with us, who's done a previous study on the turmeric product we're going to be speaking about. And so he'll be here to talk to us a little bit about that. And then also we're hoping to keep some time for some questions and answers so we can have a little bit of more of an interactive experience towards the end. I took this from Lee Silsby's website. The product that we're talking about today is called Enhansa. And basically, I think the take-home message here is, the product is pure turmeric, and they've done all the special biochemistry for us ahead of time to make sure it's absorbed well and bioavailable. And more information about that is available on their website. The things that are really interesting to me about turmeric are that, it's in our food, especially if you like Indian cuisine as I do. It's certainly, curcumin or turmeric is used very widely as a nutritional supplement. I did a literature search, and you see that there's a vast amount of information on it as an anti-inflammatory. There's also a fair amount of literature on it being an anti-yeast agent. And what's interesting is it seems like the number of papers in that arena has really been growing over the last several years. And there's also a fair number of papers that are showing increases in glutathione levels, which should be helping with detoxification, which we all know is a pretty significant issue with many of our patients. And there's certainly some studies here, and more coming all the time. And Dr. DeMio, as I mentioned earlier, will give us a brief overview of his study as well that showed some pretty dramatic improvements in glutathione levels in a very short period of time. So from my perspective, as a Lyme practitioner and as a physician in general, we speak a lot about evidence-based medicine, and the biggest problem is I don't see we have a lot of evidence for the use of different medications or supplements in general, and specifically the patients that I'm seeing. So I think that any opportunity we have to get evidence in our specific patient population is really a great opportunity that we should take advantage of. So what we set out to do was to look at the effects of Enhansa, specifically on joint and muscle symptoms in patients with persistent Lyme disease. Our study period for this initial pilot was 2 months in duration, and today we'll be talking about the first 4 weeks of that study. And in order to look at the symptoms, I wanted to figure out a way that would be, one, easy for my patients to understand, two, easy for me to interpret data so that I could have something meaningful to say and still be able to, get through the everyday aspects of my office, and then also use something that maybe other providers are familiar with. So to look at the subjective symptoms and potential changes in joint pain or muscle symptoms, we decided to use Dr. Boriscano's checklist because that's a widely available tool both to patients and physicians. And so what we did is basically I took out some different parts of that, and we broke it down by the upper extremity and all the joints there. Then we looked at the lower extremity and all the joints, 3 regions of the back, as well as muscle pain. And we asked specifically, was there any joint swelling or joint stiffness and brain fog? And those were kind of extra things I threw in. I just wanted to know in the background to see if we saw any trends. And when I was reviewing the data, I did realize that I left out one glaring part of the body. So if I were to do this again, I'd probably add in neck pain as well, because one of my patients pointed that out to me. But what we decided to do was to take the current severity and current frequency scale, and here we'll look at the current severity. And so we gave it a numeric value. So if we had no symptoms, that would be a 0, and if you had severe symptoms, that would be a 3. And the same thing would hold true on the other side. If you had a frequency of not applicable or never, that would be a 0, and then occasional, often, or constant would do the 1, 2s, and 3s, and that's how we got our data set. So all our numbers are really looking at a 0 to 3 scale. And again, just summarizing, sort of these are the variables that we evaluated. And for the presentation we're doing today, I had to make a decision to whether we're going to look at all the specific joints or a regional diagnosis. And the amount of data that we collected was quite substantial. And so what we decided to do was to clump the specific, all these specific joints, say fingers, wrist, elbow, and shoulder, into one category called the upper extremity. A little more about Enhansa. This was created by and is distributed by Lee Silsby Pharmacy. For the duration of our 2-month study, it was provided free of charge to the patients who were enrolled. And as I'll discuss a little bit later, if the patient had to be unenrolled from the study for any reason, they were still qualified to receive the full 2 months. So we weren't strong-arming them in any way. Our goal was to start out with our study in adults because there's a sort of standard titration of starting at 600 milligrams once a day and gradually increasing that to 600 milligrams 3 times a day. And certainly, I'd like to see this redone in the children in my practice, but the titration tends to be a little bit slower, and so that we didn't think we could get all the data that we needed within the study period. So that's something to look forward to in the future. And we had instructions that if, let's say, at 600 milligrams once a day, all your pain resolved, you would just stop there. Or if you had a flare of your symptoms, maybe from yeast or detox or what have you, they were to call the office, and then we would, work them through that. But we could certainly, in a time of a flare, we would either keep the dose where it was or maybe even decrease it. Medical care was provided by me, and it was just at our regular scheduled office visits. And our goal was, over the 2 months, was to not have any other changes in the patient's treatment plan if possible. And if these changes were made, they would continue to be able to use the product, but would be removed from the data set. And then if there's anything wrong with the data analysis, that's all on me because I did it. So our inclusion criteria really were patients who had symptoms consistent with Lyme disease that were persistent despite 6 months of antibiotic therapy. And specifically, we were focused on patients that had arthralgias, myalgias, and back pain. But if you've been on antibiotics for 6 months and you're still having some pretty significant symptoms, you're certainly not going to qualify in my practice as one of the easy to treat people. So we certainly were trying to pick a population of people that were difficult to treat. And then also, at some point during their history, I wanted to see at least the presence of one Lyme-specific band on their Western blot to help us, feel confident that they had actually been exposed to the Borrelia spirochete. And there's a lot of controversy about, 1 band, 2 bands, how many bands, as we're all familiar with. But I just wanted to have some baseline of where to go from, and that's, having at least a band I thought was a good place to start. So we started out, we enrolled a total of 14 patients in the study. And the results that we're going to be talking about today are from the first 7 people to return us 4 weeks of data. So we just took the first 7 people who rolled in the door with starting at a time and providing a complete data set. And all 7 of the patients who are being presented today did reach the 600 milligrams 3 times a day target dose. And so when we look at the severity and frequency data, this was pretty exciting to me because the severity of back pain was reduced, from an average over the 7 people of 1.14 to 0.79. And while it did not meet the p less than 0.05, it certainly is less than 0.1. And for a population of 7 people over a period of 4 weeks to see reduction in the severity of their back pain of that nature was really promising. And we saw a very similar change in the amount of muscle pain and how this was reduced with the same p-value. The other thing is when we look at the frequency data and how frequent someone's symptoms were, the upper extremity pain was also reduced to less than 0.1, and you can see it went from 2.33 to 1.83 as an average. And the lower extremity pain did, meet a sort of a stricter statistical p-value here of 0.025, so we saw some pretty significant changes here from an average of 2.67 to 2. And so, to me, when I first looked at the numbers here, I'm like, well, they're not all that. I mean, they're nice, but, what's the big deal about 2.67 to 2? However, if we go back and we look at our scale of 0 to 3, I think that that's an actually pretty significant change, because what we did was everything in this study I tried to put together as being the devil's advocate. I wanted to look at using the scale that we used was easy for patients and easy for us to understand, but unfortunately it made the scale very narrow. So to see changes on a 100-point visual analog scale, it would have been much easier than if I was saying, is it 1 or 2? Because the difference between, there's no halves and anything, it's just check off a single box. So it certainly made it harder for us to disprove the null hypothesis in this situation. And the other thing is the patients in this study had been sick for an extremely long time. 6 of the 7 people had persistent symptoms of some nature that waxed and waned for at least 2 years and several for 4 or 5 years. One patient had completed about 18 months of the other person who's not in that 6 had completed about 18 months of therapy after being ill for 2 years, and he seemed like he was doing very well. Then he represented and received further treatment for about 7 months prior to the study, but the second go-around hadn't been as, we hadn't seen the results that we did the first time, so he also fit the criteria. So these weren't, we didn't cherry-pick the easy people, so to speak. And then the other thing was, when I was looking over the data, when you look at the upper extremity as an example, I chose the worst score. So if someone said, hey, my finger and my hand pain was 3, and my wrist pain, was 3 or severe, and my elbow and my pain was very severe, but my shoulder, was moderately severe, and then after 4 weeks, they have this data where they have no pain in their elbows or their fingers, and they have a significant decrease in their wrist pain, but there is no change in their shoulder pain. This person received a 2. So we took the worst score that was available for the patient for that region. So, and I certainly saw that as one of the trends, is that some joints seem to respond better than others. So in our follow-up analysis of the specific regions, I think we'll have a lot more interesting information. But so we really tried to err on the side of being conservative and supporting a null hypothesis. So then when we go back and we look at the numbers of these reductions, they're actually, fairly significant improvements. The other thing that I thought was really cool, because most of my patients don't just present with joint pain or induced by Borrelia, they're multiply chronically infected like most of our patients, including Candida yeast. And a lot of people reported that they had initial headaches and or some pretty significant moodiness and irritability that generally sort of went away within the first 2 weeks of the study. And so my question kind of is this sort of a yeast die-off reaction? Could it be a toxin shift? And so that was just sort of kind of neat to see that some of the other bits of the turmeric really are coming through. And I had one patient who was not in this group of 7, but we had to withdraw her from the study because she's had some really significant Lyme symptoms that the treatment's been hampered by Candida yeast. And every time we treat her, we have some pretty significant flares and musculoskeletal symptoms, and we had her start at 600 milligrams of Enhansa, and within 2 days we had to go down to 150. So, she had to go all the way down there. We continue to treat her, but her flares are really consistent with her typical yeast flares. Another sort of interesting tidbit to me was, when I look back over the data that's out there for turmeric, a lot of people in 3 and 4 month studies show reductions in CRP levels. But what I found was that we had 4 patients who were elevated at baseline, and we had 3 of them who provided a baseline in a 4-week lab collection. And we found that the average CRP went from 30 to 38.5. And while not statistically significant, I mean, it was very interesting because we're trying to postulate why the CRP may go up. And is this an activation of the immune system? Have we detoxed things and killed off yeast that supported it? Because it certainly doesn't, fit with just anti-inflammatory properties. And also it'll be very interesting to see when we look at the 8 weeks of data and the other 13 people, or the total of 13 people who will remain in the study, to see what happens with CRPs. I did have one person who actually finished all 8 weeks because she started the day after the study started. And unfortunately, she didn't do a 4-week CRP because her CRP was skyrocketed by week 8. And then what was also interesting to me is that we had, in this cohort, we had 3 people who were actually normal at baseline. 2 of them actually followed up at 4 weeks, and their CRP remained normal, and one person said his labs were normal, so he chose not to go to the lab when we asked him to. And things for the future with our project is we're going to be looking to collect the remaining part of the data and process this. And when I find some time, I'd really like to pull it apart by each specific joint and see if there's any trends in there, as well as complete the regional analysis so that we really have a more complete data set and an understanding of what the turmeric does. And thankfully, iLabs has been nice enough to say that we'll be able to post the final data set on the members section of our website. So I think that'll be kind of neat. So it'll be out there for everyone. And this also reminds me of one thing, is when we look at the one area, the frequency of lower extremity pain, joint pain, it's really cool that that's the one that really stands out as an issue because, we can't, we use our legs for everything. And all these people were ambulatory, so it wasn't like they were in wheelchairs or laying in bed all day. They were actually walking around doing, activities of daily living. Many of them were still at work. And yet, even though they were weight-bearing all the time, using their legs to go up and down stairs, we still had that dramatic reduction in the frequency of their pain. This is a small study. I mean, certainly 14 people, and now down to 13 with the one person coming out. It qualifies as small in my book. And, I guess the question I have is does data like this, if it continues to pan out by the time we're done in another 4 weeks of the study, should we do a larger study? And then the other question, I guess, is do we really need to have another study? I mean, there's a lot of potential benefit from turmeric, and the possibility for adverse effects, when looking through the literature are very small. One of the really cool things, too, was that a couple of my patients, and one of them that really sticks out in my mind, who's a super headache patient, a headache to me, not to herself, is, calling all the time. Her back pain's been horrible, narcotics don't work, nothing works for her. And if you don't fix her within 2 minutes after her leaving the office from any given office visit, you receive a phone call later that day. Says, I don't ever want to stop this stuff. She had a really dramatic decrease in the frequency of her back pain, for which she's had injections and all kinds of other things on top of her narcotics and her antimicrobial therapies. So when talking to her, and then I was I couldn't wait to look at her data. I figured it went from a 3 down to a 1 or a 0. And I didn't see the huge shift. I certainly saw a shift that went from 3 down to 2 consistently, but, so it was very severe down, or constant down to often. But then I started to think more about how limited our scale really is. This is a person who had a very dramatic change in her quality of life, and it was just reflected as a simple 3 to 2 change. So it was a very small change on our scale, but a huge change in her life. And that really made me think about the way I collect data in my office, because I use a very similar scale just to follow up with my patients, and it's sort of a limited scale. I mean, Here, because we only have a small amount to go, but even though we only have a few small choices so we have to have a pretty drastic change to actually register it in our scale here, it kind of confirmed to me that, one, it's hard to get that information, but when we do see a shift in our office data, it's typically a very significant one. So, the take-home messages here are, that Enhansa has led to some pretty significant improvements, especially in lower extremity frequency of pain, as well as upper extremity frequency, and then back and muscle pain severity. Curcumin in general has been very well supported to be anti-inflammatory, antifungal, and also to increase glutathione in the literature. One of the other things that we always have to remember is that there are the potential for flares, as in any of the therapies that we do. But in my experience, both with this study and using Enhansa outside of the study group, the flares are fairly manageable in the similar ways by promoting detoxification and all the other things that we're used to doing on a daily basis. So curcumin is safe and effective in my opinion, and I think the literature really supports that. And what's really nice is that sometimes I can even see improvements that are fairly drastic within 4 weeks of therapy. And as a quick side note in ending, some of our patients actually, when I'm looking ahead to the second data set, actually around week 6, I see another blip, and that sort of people start dropping off in the severity and frequency of pain. So hopefully that'll bear out, and there'll be some statistical significance behind that. So hopefully the next time we present the data, we'll have a little bit more information to talk about. So I'd like to really thank you for the time listening to me. Dr. DeMio, I think, has a couple of slides to talk about the study that he's done, and then we'll make sure that we have a few minutes if anybody has any questions.